Good morning, everyone, and thank you for joining us this morning for our falls prevention in hospital settings workshop. I'm Angela Jones. I'm the Chief Operating Officer for Monash Partners Academic Health Science Centre based in Melbourne, and it's my great pleasure to welcome you all today. This event is being brought to you by Monash Partners, the Melbourne Academic Centre for Health and Western Alliance. The three centres are three of Victoria's academic health science centres and working very closely and collaboratively on behalf of Western Alliance and MAP. I extend a welcome to you also. There's been extraordinary interest, as Kathy has said, in this event, and we have participants from across Australia, a lot of interest across Melbourne and Victoria, but also from interstate. And I also believe we have a number of participants joining us across international borders also. So welcome to you all. I think it reflects the enormous challenge that we have around preventing falls in inpatient care settings. And we hope that today's session is one that's really useful for you, especially for those of you working in healthcare settings and on the front line. As an overview, we know that falls are a leading cause of preventable harm and suffering in healthcare settings. At today's workshop, we have a series of leading researchers presenting research on hospital-based falls prevention from a number of different perspectives, and we'll have a series of presentations. We circulated prior to the workshop a pre-workshop survey. Many thanks to those of you that completed that. We've formulated some questions based on the responses to that survey, and there'll be some discussion about that after our series of presentations in the first part of the seminar. Just to let you know that today's seminar is being audio and video recorded. We also have the chat function, which we'll be monitoring, and we'll save that because we find that's a really rich source of data from these events. I'd like to acknowledge the traditional custodians of the land on which we're standing, and in a spirit of reconciliation, I pay my respects to elders past, present and emerging. We extend respect to any Aboriginal and Torres Strait Islander people joining us today. Wherever you are, we acknowledge and pay respects to our First Peoples. Just to run through the program a little bit for the morning, we're together for the next 3 hours or so. In a little while, I'm going to hand over to Associate Professor Kathy Sade, who will be the facilitator for today's workshop. Following, and Kathy will have a presentation from Margaret Thomas on the consumer perspective around falls, and then a series of presentations which will present the scene around some of the latest research in falls prevention in health services, some work that's been done across the Monash Partners Health Services around mapping falls prevention strategies, some new approaches, a presentation around co-design of hospital-based falls prevention interventions, and also a presentation focusing on some of the challenges in patients with dementia. Just to mention, Monash Partners, MAC and Western Alliance are each large-scale partnerships. Each of our centres brings together numerous research, teaching and health service organisations. And the centres exist to try and get better integration across research, education and clinical care, and most importantly, to get evidence into clinical care so that it benefits patients and our community. Following our series of presentations, we're going to move to a panel discussion, and then we'll have some closing remarks at the end. The panel discussion will be a chance for you to ask questions and engage and hear from our panel members. What we'd like to do to make this webinar interactive and also enjoyable for everyone, we're going to use a tool called Poll Everywhere. And there will be an opportunity throughout the workshop this morning for you to answer questions and provide your feedback. I'm going to take you to a slide in a moment which will guide you around how to log into that. but also we wanted you certainly to please use the chat function for the webinar today. Ask questions, share your thoughts and experiences throughout the seminar. There will be a number of the team monitoring the chat and responding. And then we have a brief feedback survey at the end of the seminar to hear from you about suggestions for future events, and your feedback on this seminar would be enormously useful to us as well. So how to join for our Poll Everywhere component today. If you're sitting at a laptop, you can log in via the internet, and the address is there, and then you enter Monash PARTNE 784. Alternatively, if you are at a mobile phone or a smartphone, you can send an SMS message to the number there, 0427 541 357, and again enter the code, and you should receive a message that has indicated that you've joined the Monash Partners session. So I'm just going to pause for a moment and allow everyone just a minute or two to do that. And when you've logged in, you should get a test question around which is your favourite tune, with 4 options. And if you could go ahead and just answer that and select A, B, C or D. Okay, thanks everyone. I'm now going to stop sharing my screen, and I'm going to hand over now to Associate Professor Kathy Said, who is going to be our facilitator today. Kathy is the inaugural Associate Professor of Physiotherapy. She's based at Western Health and the University of Melbourne, and she's also a Program Director with the Australian Institute of Musculoskeletal Science. Kathy has combined research with a clinical career and has over 25 years experience working in public hospitals, predominantly in neurological and aged care rehabilitation. Her research focuses on falls prevention and rehabilitation of older people and people with neurological disorders. And thank you, Kathy, for facilitating today's workshop, and over to you.
Thanks very much, Angela. So hopefully today I'm going to keep us all to time and keep things moving along. I'm really excited to be part of this, and I have to say I'm really thrilled to see so many people join it. At the moment I can see we've got 245 participants, which I think completely surpassed our expectations when we started. So our very first person we're hearing from today is Margaret Thomas. So Margaret is going to talk to us about her experience as a consumer from that perspective. So Margaret was born in Sydney in the middle of the Second World War. She was the eldest of 3 children, and the family moved to Melbourne in 1972. And over the next 15 years were committed to raising a family, caring for a mother and caring for her late husband who had dementia. After participating in the Victorian Government's Dementia Task Force as a carers representative, Margaret was asked to join the Department of Human Services to work on policy development in dementia, acquired brain injury and falls prevention portfolios. To complement this work, Margaret completed a postgraduate diploma in health promotion in 2005. I think this is a really great example of how a consumer perspective has really influenced policy and procedures here in Victoria. Since retiring in late 2012, Margaret has spent a very busy 9 years sharing the care and education of a 7-year-old grandson. We all love grandparents, volunteering, gardening and keeping fit by actively participating in water aerobics, walking and Tai Chi. So I'm going to hand over, I think we've got a video of Margaret that we're going to play. Just a minute, everyone. As we know, tech it always brings up a few little issues. So we'll have the video playing in just a minute. And I have seen a few people asking if we can repost the poll details. So again, we'll get that located in the chat for you. So we've got a little bit of time before we'll need to do the first poll. And it looks like we're right to go.
Good morning, and thank you for the opportunity to share some of my experiences and observations about Good morning, and thank you for the opportunity to share some of my experiences and observations about falls in hospital. I would like to discuss how important the value of being treated as an adult is to me, the placement of furniture and walking aids in the room, and discharge planning. If after today I have given you a better understanding of my perception of how easily falls can happen in hospital and what may stop them happening, I've achieved my goal. Coming to terms with your own ageing is confronting and challenging. Few older people manage to get through life without issue, be they family, health or financial. Having a fall has become much publicised, with the recent fall of our Premier and the fall-related death of well-known fashion designer Carla Zampatti. These falls were in the home and the community, but many falls take place in the hospital setting, and it is these falls our eminent group of clinicians will talk about today. I will speak from an older person's perception on how life-changing a fall can be. It is when you're at your most vulnerable from either illness or surgery, falling can make the difference between a successful outcome or a bad one. It can add weeks to hospital, to the stay in hospital, painful and time-consuming rehabilitation that is not always successful. It can result in going into residential care, or in the worst-case scenario, you can die. My nursing friends would tell you that they dread people falling in hospital, the guilt of it happening on their watch, the resultant paperwork, and possible legal repercussions for the hospital. They consider many falls are the result of people being impatient at not being able to independently toilet themselves. For those who are not cognitively intact, this takes on a greater significance, as bed rails are often used to prevent people with dementia falling, slipping, sliding or rolling out of bed due to poor mobility, visual impairment, or even the effects of medication. The risk of people climbing over the rails or trying to get out of bed by squeezing through the rails is always a possibility. Families are often unaware of their relatives' lack of perception and consequently their increased risk of falling. Staff need to discuss with families on admission the benefits versus risks associated with bed rail use. Some years ago I had back surgery, laminectomy and fusion of my lower spine. Post-surgery I was required for 6 weeks to be either lying prone or standing up. Being a very independent person, this was challenging as the nursing staff insisted on using bed rails for the first few days to compensate the effects of anaesthetic. I found this quite demeaning, as after the second day, it ensured I had to seek help every time I wanted to get out of bed to go for the twice daily walk my surgeon had prescribed. In a busy ward, it's not always possible to get help at the time you want, and frustration can set in. Change of staff times often meant nurses forgot to help you before the end of their shift, and new staff were initially too busy to help. Reflecting on this, I realised the issue that irked me most was being treated as a child. I knew I was a significant falls risk, and I was well aware when I needed someone to help me get out of bed safely. To remove any temptation, my walking aid was placed well out of reach, the reason being so someone coming into the room would not fall over it. And to add insult to injury, the call button was invariably lost among the pillows. As a natural right-hander, I found it annoying, the habit the staff had of locking the top drawer in the side cabinet to accommodate medications. I questioned why couldn't the medications be in lower drawers, leaving the top drawer for me to place my reading material and glasses. As a cognitively intact adult, I was well aware post-surgery my physician was modifying the amount of blood pressure medication I was taking to reduce my falls risk. I did not need to have my medications locked away, as I knew how much damage a fall could be. It is different for people who are cognitively challenged, and most staff would be well aware of this from the pre-op information provided. Having a drip inserted into my arm meant there was no easy access to the drawers either, as they were invariably blocked by this equipment. Drawer lockers that could be moved from one side of the bed to the other would have been a great help. The forms filled in prior to admission seldom ask if the person is a natural left or right-hander, so that the placement of room furniture could be adjusted prior to this type of surgery. On another occasion, while holidaying in New Zealand, I tripped over a tree root. After the shock of the fall, I managed to pick myself up, dust myself off, and celebrate the fact that I had not suffered an injury, just an injury to my pride. Some months later, I ended up in hospital, fortunately back in Australia, to replace breast implants I had unknowingly ruptured in the fall. These were the result of a bilateral mastectomy, not vanity. Reflecting later on possible consequences, I thought about what could have happened as a result of injuring myself in another country, interrupting a holiday long planned and anticipated, having surgery and rehabilitation in that country, or arranging for family members to travel to escort you home for surgery and rehabilitation. While travel insurance may have covered most of the costs, you realise life would not be back to normal for quite some time. Over many years, I have been asked to contribute to finding a cure for cancer, dementia, heart disease, any number of worthy causes. Until today, no one has ever asked me to talk to clinicians, nurses, doctors, and people working in the hospital setting about ways to prevent a fall by considering sensitive assessment of your patient's physical and psychological needs, placement of furniture and walking aids in the room, discharge planning, what needs to be done next, does the person live alone, who will care for them at home, if they have a partner, is that partner capable and or willing to care? Is the home layout suitable for someone recovering from a fall? Do they need residential care? The list is endless. It is not until you are face to face with the consequences of falling that you realise how life-changing an injurious fall can be. I trust you will find these observations useful and consider building them into your very busy professional practice.
Thank you very much, Margaret, for that. It's always really brings us back to why we're doing this when we hear about things from a consumer perspective. And it was really, you know, we're very thankful to you for sharing that story with us. Margaret's going, did you have anything you wanted to add at the moment, Margaret, or we'll have you back on the panel if there's anything else you'd like to share with us then?
I did think of one other thing that I hadn't mentioned, which was the problem that you face when walking through the general passageways. If cleaners leave buckets, vacuum cleaners and mops against the wall. And this was one thing that could have put me at great risk, as I had to leave the safety and security of the railing to negotiate around it. And we sometimes think in terms of falls being the responsibility of the nurses and doctors, but we forget those people who also provide ancillary care in the way of providing meals or the cleaning staff. It's just a thought.
No, thanks, Margaret. And I think it's always really valuable to hear, you know, thoughts from the consumers. I think when we work in hospitals, it's very easy for us to just take things as this is just the way they are. And I think it's really useful to have a fresh perspective on things. Now, I've just been looking in the chat. I can see that some people are having a bit of trouble with audio. The audio is fine at our end, so there might be issues at your end. But I think the other thing is don't stress if you can't hear things or you're missing things, because the session is going to be recorded and it will be available. So you'll be able to catch up on any bits you miss. And for people that missed the poll, more information on the poll again is placed in the chat so that you can join there. So now I am going to hand over to Professor Meg Morris. So Meg is a physiotherapist and Professor of Clinical Rehabilitation and Rehabilitation Practice, which is a joint position between Healthscope and La Trobe University. She has a particular interest in hospital quality and safety, especially hospital falls prevention, which is right up our alley today, and has published extensively in that field. So I will hand over to Meg.
Thank you very much, Kathy. And can you hear me okay? All good? Great to see you, everybody. And it's wonderful to see that we've got well over 300 people here today, which is just fantastic. I'd like to give a special thank you to the clinicians at Healthscope and all of the ARCH sites who have helped me prepare this presentation today, and also to my research collaborators and everybody joining us here today. I'm just going to remove this floating screen. Okay, so my talk today is on the latest research in health services falls prevention. As many of you will know, I'm a physiotherapist and a falls researcher. And what I've done today is try and distill down some of the latest findings of research evidence into practical applications. Just trying to get that to move down. Okay, so falls remain a persistent and very major problem in Australian hospitals. They are a major cause of serious injury and increased length of stay in people. And they're a really big problem because we know that there's over 44,000 falls every year in Australia's public hospitals. And this costs our Australian economy more than $1 billion every year. And of course, as well as the cost to society, there's huge cost to individuals because falls come with pain, disability, the fear of falling, and long-term impacts on health and well-being. Now, many of you who work in hospitals and other settings will know that hospital falls are very, very common, and there's a huge range of risk factors. So the sorts of risks that people can find in hospitals, the things that increase the risk of having a fall in hospital are a history of falls, confusion, delirium, altered mental state. People with cognitive impairment or dementia have a particularly high rate of falling, frailty, advanced age, multimorbidity, risk-taking behaviours, things like mobility or balance impairments, weakness, reduced aerobic capacity, polypharmacy, syncope, poor nutrition, altered sleep, visual impairment, chronic illness, altered urinary and bowel syndromes, poor footwear, unfamiliar surroundings, and environmental risks, such as the unfamiliar environment of a hospital, clutter, and slippery surfaces. So that's only some of the risk factors for hospital falls. And I think today what we'll be doing is seeing how we as clinicians and as patients and healthcare administrators can work together with the policymakers and researchers to try and reduce the rate and the risk of falling in hospital. We do have a big challenge on our hands. So all of us need to work together collectively. We need to bridge the gap between the research evidence and what's actually happening out there in clinical practice. We do now have ample research evidence on hospital falls risk factors and mitigation strategies. But the trouble is that most patients don't actually think they're at risk of falling in hospital. They think that because they're in hospital and they're being cared for, that they're not so much at risk, when in fact all hospital adults are at risk, and especially those over the age of 55 can be at a high risk of falling. Also, clinicians know that there's a vast body of literature out there, more than 6,000 articles, but they're unsure how to implement this research evidence into practice. And also, we need a culture of vigilance in hospital settings around falls prevention. Write them from the very top about this is a really high priority, and we need the behaviour change at clinicians, in managers, in researchers, in policymakers, and in patients themselves. So together we can tackle this problem. And I think as a setting for today's talks, I'd like to present this research translation framework. It's one by Graham that I particularly like, that we can use for rapidly translating falls research into clinical practice. So in the middle of the triangle there, you can see we have all of this knowledge now available from primary studies, randomised controlled trials, non-randomised trials, systematic reviews, qualitative research, clinical guidelines, care pathways, and a whole range of tools and resources that are actually currently available. But we need to work together to work out an action plan to identify the problem at your local site, to adapt this knowledge to your local conditions, to find out at your site, in your hospital, what are the barriers to knowledge use. Select and tailor the interventions to meet the needs of your hospital and your patients. You then need to monitor knowledge use, evaluate outcomes, and sustain the knowledge use. And that becomes a cycle over time. So in this brief talk, I thought I would bring to you what my advice is. The key sources of falls research evidence are the UK NICE guideline and pathway. And if there's any take-home message, please go to that website and look at the NICE guideline and the pathway. This gives you an evidence-based summary and also a pathway that you can use in your hospital. Also, Ian Cameron and team did a fantastic Cochrane review on hospital falls, and that's currently being updated, but it's still very valuable to go to the Cochrane site and look at that. And also our own team, Terry Haynes, and all of the speakers here today are doing research trials, and we've just finished a systematic review on hospital falls, and they're a great source of evidence as well. So this is a NICE guideline website. Please go there and you'll see this is pathway on preventing falls in older people with a subsection on preventing falls in people over the age of 50 in hospitals. We all really should be using that existing guideline and implementing it into our local site. And this is showing you the link to the Cochrane review. Again, a fabulous summary on interventions for preventing falls. There is more recent data, so we have updated it, and you'll see the updates over time. So given the limited time, what I thought as a researcher and a clinician, what would I want to know about preventing falls in hospital? And the key message here is there's different levels of evidence. There are some randomised controlled clinical trials. There's a vast range of non-randomised trials out there. And there's a huge number of qualitative studies and also reports. And so I've colour-coded these. Green is the highest level of evidence. Red is the lowest level of evidence. And then they've got a lot in between. And just because we have a low level of evidence doesn't mean it doesn't necessarily work. Sometimes it means that research hasn't yet been done in that space. So the highest level of evidence is around patient education. Margaret Thomas's talk was really spot on. We actually need to work with the patients themselves to co-produce and co-implement evidence into practice. clinician education, and then there's some emerging evidence around assistive devices, especially using the call bell, physical activities and strength training, vitamin D, medication review, environment and footwear. And I'll go through these now with you. What we've done at HealthScope is we've taken all the research evidence from the clinical guidelines, from the literature, from systematic reviews, the Cochrane reviews, and we've created this 7-step falls prevention model that I thought you might like to hear about. This 7-step model puts a point around using this as single interventions or multifactorial interventions. Educate the patient and their families. Educate and train clinicians so they're capable. Ensure we have environmental modifications, appropriate assistive devices and using them. Look at the service model, the auditing, the policies and procedures at your site to make sure that they align with clinical guidelines. Look at rehab, physio and other interventions. And of course, leadership and empowerment of people across the whole hospital system to create this culture of vigilance around falls prevention. So very quickly going through this, patient education from our systematic review and others has currently the most robust evidence. So what we need to do is educate people where possible. Please use the call bell. And for the staff, please respond to the call bell, because we find that many falls happen in the bedroom, in the bathrooms, when people are trying to get to the toilet, especially, or get out of bed. We need to show people how to use the call bell. It's there for their safety. Please use it. Call, don't fall. The bathroom and the toilet, when you look at your falls data in your hospital, you'll see that the majority of falls happen here in this trouble spot. So many falls occur in the bathroom. So if needed, use the call bell and wait for assistance. It can be frustrating, but we need to wait for assistance. Don't rush, and be very extra careful with slippery surfaces or water on the floor. And of course, as clinicians, we need to try and make sure we don't have water on the floor. There's now evidence from Hilton Menzies Group and others showing safe footwear in hospitals are particularly important. So we want to get rid of these scuffs and these slippers and these slippery socks, and ensure where possible when people are ambulating, they wear properly fitting shoes. And create patient falls brochures like we have here at HealthScope, which are co-designed with the patients and the families themselves. So you can see that they've got nice big writing, clear messaging, and it's understandable and being tested by patients. So they find it a useful resource to use in the hospital setting. So each patient is given a brochure and a conversation about, do you realise that because you're an adult in a hospital, you're at risk of falling? And we want to work together with you to prevent your falls in hospital. So clinician education also has, a reasonably high level of evidence that's growing over time about clinician education and capability building is really critical. So we need to put in place, we've actually put in place at HealthScope a community of practice around falls prevention across our 43 hospitals. But in there we have a WebEx site with a whole stack of resources, not only the clinical guidelines and the pathways and our policy, which has just been updated on falls prevention, but also these sorts of ideas and resources like stickers we've developed for staff to wear to prompt conversations with patients and visitors about their falls risk and how to mitigate hospital falls. Education sessions on a regular basis for the clinicians, a falls resource kit. We've been holding post-fall huddles in our hospitals. We have an April Falls Day promotion in April. We have staff quizzes and prizes. We develop slide sets. We've got videos. We've got podcasts and a whole range of different resources that they can use. And importantly, we make sure we store these resources so each individual clinician is not reinventing the wheel. As part of this resource kit, we are promoting walking, balance and exercise in hospital as appropriate, especially in rehab hospitals. If you have a walking stick, crutches or frame, make sure that it's in easy reach of the patient and that they use it every time they mobilise. Because again, looking at the falls data, often they have a walking frame, but they've tried to get to the toilet without using it, and that's when the falls occur. Don't rely on furniture. Take your time when multitasking. Special care with steps, stairs, slopes, ramps and uneven ground. If prescribed, do rehab and exercises as shown by your therapist. And this will be talked about this morning, but the person's mental state is really important. People with confusion or altered mental state are at really high risk of falling in hospital, and they do benefit from extra assistance and extra planning from the clinicians. And family and carers can assist the staff by alerting them if they notice a change in their relative's mental state. So it's a team approach. We work with the families, we work with the patients themselves. We take special care if they have cognitive impairment. We need to do regular checks of our environment. Audit your environment in the hospital because it's unfamiliar to the patient and that it might need modifications to make sure the person's not at risk. It can be dangerous, especially if they have inadequate lighting, slippery surfaces, worn carpets, staircases, lack of railing, or clutter in the room. So please, everybody, declutter the room. Assistive devices are many and varied and need to be used. So here it's about the behaviour change in the clinicians and the patients themselves to ensure that we have very good use of these devices once prescribed. And last but not least, I'd like to emphasise the importance of research on leadership to prevent falls. So leadership at every single level, leadership from researchers, the research community, leadership from policymakers, leadership from the hospital administrators, leadership from the hospital managers, leadership from clinicians, leadership from the patients. All together, we need to ensure that we engage leadership to create this culture of vigilance about falls prevention. We need to measure and continuously evaluate the effects of our implementation strategies. We need to collaborate with all disciplines. It's not just up to nursing, it's all of us. I think it's great to identify nurse, allied health and medical falls champions or knowledge brokers to help get this implementation of knowledge into practice. Tap into the wisdom of the front line. There's huge wisdom out there. We need to use it. And we need to hardwire practices and educate clinicians and patients. So very finally, it's really critical we set up sustainable systems at each and every hospital site. I suggest that you set up a falls prevention group, and the group could meet regularly and audit the falls data and respond to your own local falls data, report up through a quality structure, set clearly defined goals and an action plan, implement evidence-based practice based on the guidelines and the research findings, benchmark your falls very regularly, and make sure that we're a team, the clinician, patients and researchers, we all work together. Thank you.
Thanks, Meg. Now we have got 2 minutes for one question. So there's a question in the chat which is about the Australian guidelines, which were written in 2009 for hospitals. Do you know when these are going to be updated?
I'm not sure where they're going to be updated, but what I can say is that we know that the international guidelines are currently being updated, and many of the researchers, yourself included, Kathy, and Francis and Terry and others and Keith, were involved in this consortium internationally to update the international guidelines. And I think that it's a really good idea that we look to these international guidelines and the UK NICE guideline that I talked about, and we should be using those. That's my personal view, because I think, you know, we've got worldwide experts that put knowledge and skills into that. So let's use the world's best approach.
Thank you, Meg. So we will now move on to our next speaker, who is Professor Allison Hutchinson. Allison is the Alfred Deakin Professor at the Nursing in the School of Nursing and Midwifery at Deakin University. She's the Director of the Centre for Quality and Patient Safety Research in the Institute for Health Transformation at Deakin University and holds a chair in nursing at Monash Health. Her primary research interest centres on improving care through knowledge translation, and she's going to be talking about mapping of falls prevention strategies across Monash Partners Health Services. And I can see we've just got a poll up there now, which is looking at what is the best way to prevent hospital falls is for clinicians to assess a newly admitted patient using a 0 to 10 rating scale.
I was just going to talk about that in my time.
Oh, sorry, Meg,
have I?
Oh, no, you can have 1 minute to talk about the results.
So, because it links
Sorry.
with other talks this morning. So, very quickly, one of the points that I often get asked is, do we use these falls risk assessment tools? You know, because I gave that great list of all those risk factors for hospital falls at the beginning of my talk. Should we use one of those 10-point rating scales to spend time rating out of 10 a patient's falls risk in hospital? And is that very helpful? And I was going to say that the talk following up from Terry Haynes, and I think Keith is touching upon this as well, shows it's best if we actually don't, in a sense, waste too much time on such a scale, but rather that we actually look at the patient as an individual, assess their individual needs, quickly assign mitigation strategies for that individual, and then make sure that they're implemented. So the implementation here is really critical to audit the fact that we have implemented and to chart that over time. Thanks, Kathy.
And we've got a second poll here, which is, which of the following statements is incorrect? And again, Meg, is this one of your questions or is this Allison's?
Yeah.
Yep. So we'll quickly go through this. I'll give everyone a bit of a chance to respond. And I'll hand back to you, Meg, to talk about
here,
this.
yeah, it's incorrect to say that hospital patients themselves can't learn. No, we need to assume, we need to work with the patients. We need to assume that they can learn, and we need to work together with them to meet their learning goals. Thank you.
Thanks, Meg. Sorry about that. And I now will hand over to Allison. Thanks very much. You're on mute, Allison.
Yeah, sorry. Just trying to negotiate all the different screens. So are you seeing my presentation screen at the moment?
Yes, we are.
You are? Terrific, thank you. That's great. So thank you, Kathy, for that introduction, and thank you very much for the opportunity to speak today at this webinar, which is, you know, it's fabulous to see. We've got such wonderful engagement and numbers here today. So it's really, I'm talking about a very important topic. So I'm going to talk about a piece of work around mapping of falls prevention strategies across the Monash Partners health services. And this was actually a large team who I would like to acknowledge at the beginning, number of clinicians and researchers across a number of Monash Partners organisations. We've had a really great introduction from Meg about the importance or the reasons why falls prevention is so important. So I'm going to jump straight into the aims of this project. And the aims were specifically to map falls prevention activities across the health services and to estimate the cost of those activities, particularly focusing on prevention of falls and prevention of harm from falls in patients. And the specific research question was what activities are hospitals undertaking to prevent falls and harm from falls, and how much does this cost? So this was a mixed methods study, and it was a cross-sectional study using semi-structured interviews with key informants. It involved 6 health services, and combined across those health services were 28 hospitals included. From each of those hospitals, or from each of the health services, there were one acute, one subacute and one mental health ward selected randomly from each health service for inclusion. And the interviews were with purposefully selected key informants. So they were people that were leading falls prevention projects, quality managers, and organisational leaders, as well as representatives on each of the wards, the acute, subacute and mental health ward, and capturing a range of disciplines, so nurses, doctors, allied health professionals, pharmacists and so on. So really trying to capture a range of perspectives in these data. And the participants were asked, the interview guides were tailored according to which particular group the participants were from, to try and capture sort of relevant data particular to their particular work. And they were asked where and how falls prevention resources and equipment were used, and the time that they were invested in falls prevention activities. So they were asked to report the time and the resources used for a range of activities, including those listed here. So committees, education time, project work, procedures and guidelines, assessments, moving patients from to low beds, from standard beds, moving patients to supervised positions, equipment such as non-slip stocks, using falls prevention alarms, continuous patient observers, educating patient and family, physio and OT therapies, and the post-falls management, as well as the reporting and documentation that they do. And they were required to really estimate the time that was involved in each of those activities. The analysis that was done across the data, the activities were all mapped and across a 1 year period. So activities that were repeatedly undertaken, that was all calculated out. The EBAs for the particular groups were used in estimating the cost of staff time, and they were multiplied by the number of bed days of acute, subacute and mental health wards. So essentially what was calculated in an organisation for the acute care wards was then extrapolated out across the number of wards in the organisation, and a cost per bed was calculated because clearly wards often have different numbers of beds. And the opportunity cost for each activity is then estimated. So this refers to the benefit that a person could have received but gave up in order to take another course of action. And the opportunity cost of a person's time is their wage or cost of employment. So that was calculated. Now, I actually had a couple of questions that I wanted to ask you, so I might ask if those questions could be put up, and I'll need to stop sharing, I'm guessing, Kathy. So I'll stop sharing and ask if those questions could be put up before I move into the results. So the first question is, what falls prevention activities consume the most resources? Okay, so we're looking. Okay, so most people think it's the continuous patient observers. Great, thank you for that. So we've got one more question for you. On average per year, what approximate amount does a Metropolitan Health Service spend on falls prevention activities? This is a hard question. Okay, terrific. So we're saying around about 7.5 million. Okay, so Kathy, if you unshare, and I'll reshare my screen, and we'll share the right screen. Okay, so then I'll move on to my next slide. So there are 186 interviews conducted, and the average amount per health service for prevention of falls per calendar year was about 7.6 million. And so those people that said around about 7.5 million were correct. But it is, I mean, that was a very hard question for you to answer. The average bed, per bed cost in Australian dollars was $9,215. So quite a lot of money when you add that up across the number of beds in a hospital. So in terms of the activities that were undertaken, 18% of the cost went to physiotherapy. So most people thought it was continuous patient observers. 14% was for CPOs, 12% of the cost was for falls assessment. Falls prevention alarms, 11% of the cost. Risk screen for 8% of the cost. And informal patient education, 8%. So I haven't given you all the, because there are a number of other categories of resources, but much smaller percentages. But you essentially see that physiotherapy was the most consumed resource in terms of falls prevention activity. So what we found was that there was really wide variation in falls prevention spending across health services. That probably comes as no surprise to you. And we believe that this could be attributed to the makeup of specific wards. And it may be that the wards that we randomly allocated actually influenced that. And some health services also didn't have really good records of some spending, so it was rather you know, complicated to try and calculate when the records were not as reliable as they could be. Annual opportunity cost estimated was estimated to be 46 million across the 6 health services, and when you extrapolate that across the country, that's $590 million per year in resources to prevent falls in Australian hospitals. So it's really a significant amount of funds that actually go towards the prevention of falls. And I guess, you know, what we've been talking about in terms of falls prevention, if we can avoid the falls, then some of those funds might then be able to be used for other purposes, of course. There were limitations to this study, as there are with all studies. The wards were varied, and so were the reported falls prevention activities. People had trouble estimating the time taken to undertake activities, which is, again, you know, it is quite hard to estimate, although we were encouraging them to use records and documentation that they had in order to inform the interviews. And there were some prompts about equipment, but we generally in the interviews tried to enable people to put forward their own ideas without prompting. So to conclude, health services are investing a considerable amount of resources into falls prevention. Much of the resources are put towards activities with weak or little evidence of effectiveness, and Meg's really given us a nice overview of the levels of evidence. Health services may be better served by focusing on reduction or disinvestment of some of those activities, and then the funds could then be, or those resources could be directed more towards other activities in supporting prevention. And for example, structured patient education we've talked about. And I'd like to just, if you would like to read about this piece of work, this publication is available in the literature, and it details the project that I've just presented, so you can get much more detailed information from the publication. And I'll stop there.
Thanks, Alison, for that. We might move on to Terry so we can keep to time, but again, if people have got questions, we can maybe pick them up in the panel discussion. So Terry is, I've just got to flip to my other page, sorry, head of School of Primary and Allied Healthcare at Monash University and a member of the National Centre for Healthy Ageing. He's led multiple trials of fall prevention strategies in the hospital setting, and I'm sure his name is well known to many of you listening today. And he's previously served as president of the Australia and New Zealand Falls Prevention Society. So Terry today is going to be talking about a new approach to changing practice and finding out whether our falls prevention strategies are effective.
Thanks very much, Kathy. I might share screen now and get us going with this part of the presentation. I assume that's coming up now. Okay.
Yes, it is.
Well, today I'm sharing with you about a new approach to changing practice and finding out whether our falls prevention strategies are effective. To begin with though, I'd like to start off with a poll. Please select the option that best represents your view on the falls prevention activities your hospital employs for its inpatients. Are you highly confident that these activities are effective and a good use of staff time? Are you uncertain that these activities are effective and that maybe they're not a good use of staff time? Or are you highly confident that these activities are not effective and are not a good use of staff time? Now, just give a second for that poll to be conducted. I think it's A, B, and C. I'm not sure what you have to actually select for this particular poll. Put that in for those of you doing on your mobile phones. All right. Now, I can't actually see the poll result. Kathy, did you want to tell me what the poll result was?
I can see a message in the chat saying people cannot poll as it is full. So we may have a little glitch here. I'll hand that over to Kathy and Victoria to maybe sort out. So maybe if we just move on, Terry.
All right. Well, let's go back then. Okay. Well, let's talk about how we find out whether a falls prevention intervention is effective. Now, you've heard some talks already about the effectiveness of falls prevention interventions. There's a diversity of views in the falls prevention community. I don't know if you've ever been to a falls prevention conference, but we'll quite often end up with questions at the end discussing our different views on the falls prevention evidence. But generally, there's a consistently agreed approach to finding out whether falls prevention interventions are effective. Generally, we run experiments where there's an intervention group and a control group. Now, the intervention group and the control group get compared, and usually they're randomly separated, or they're separated through some sort of random process. Now, we want to see that they're fair, that we're comparing apples versus apples, of course, but all of this is happening on the background of usual care. Now, what is a part of usual care? Well, that will vary depending on your site, but as we've heard from Allison, there's a number of interventions that are often included. There might be risk alerts, there might be exercise programs, education programs, there might be bed alarms, there might be non-slip socks, there might also be, and this is what I consider to be potentially the most important falls prevention intervention, it's the care that's provided on a one-to-one basis by the nurse looking after the patient. So even though we don't often think of it as a falls prevention intervention, to me, it's the most critical one. Now, the problem with testing falls prevention interventions is what happens if they're already a part of usual care? We've actually gone out and done a whole range of falls prevention activities before we've actually developed the evidence base as to whether they work or not. We've put the cart in front of the horse, so to speak. So as a result, we need to think about things that we're already doing that we might not be sure about. So why do this? Well, we've just heard about the costs of certain falls prevention activities. If we look at the bed and chair alarms as an example, from the study that Allison was talking about, we estimate that about $58 million per annum is consumed primarily in staff time providing this particular intervention. Now, if you look at that and the evidence that supports whether it works or not, here's an extract from the Cochrane review indicating that this intervention has a very uncertain effect on falls. The point estimate is maybe a 7% reduction, but the 95% confidence intervals around that are really wide. So it could be a 60% or 62% reduction, or nearly a doubling of the rate of falls which this intervention brings about. So there's a lot of uncertainty here. Further to this, we know that about half of the false alarms that go off are false alarms, and that it takes about 60 seconds for staff members to go and respond to an alarm if they're not in the room when the alarm goes off to begin with. So you could say that, well, even if it's a correct alarm, the staff probably aren't going to get there in time before something happens. We also know that there's things such as sleep interruption, staff processes being interrupted, and that family and patients have complained about them in the past. The other thing is that the effects might be broader than just the patient with the alarm. It could also be that other patients in the ward. When patients in the ward see that staff are very busy, it induces patients to take risks. Patients see a busy staff member and say, I don't want to burden them. I'll go and do my trip to the toilet on my own because I want to be a good patient who helps. So it can actually affect more than just the patients who have the alarms. So with a conventional research approach, if we were to say, right, we want to give our experimental group bed alarms and our control group no bed alarms, but that bed alarms are a part of the usual care background, we've got a difficult job as researchers. We've got to go to people and say, hey, would you like to be a part of our research? There's a 50% chance you'll get a bed alarm, a 50% chance that you won't. But if you don't want to participate in our research at all, there's a 100% chance that you'll get the bed alarm if you need to. Now, this is a difficult sell. And if you can manage to get a research project successfully up and completed with a reasonable cost, doing so, then my hat is doffed to you because that is extremely hard. What we quite often need to think about is, well, what is usual care and does it actually need to be there? Could we remove it from usual care so that we can find out whether it works or not? Back in 2013, a team that I worked with developed a new approach to trying to figure out if things that were a part of usual care were effective or not. We used what's called a stepped wedge research design, which is a form of cluster randomized trial where wards, in this case were referred to as clusters, that they're randomly allocated to transition from a control condition to a intervention condition at randomly selected time points. What we did with our disinvestment approach is we realized that everyone started with the intervention and should actually transition to a control condition. So going from white to black in this diagram. And that as you do it, you need to do safety assessments and use a non-inferiority paradigm as a part of the design. Now, in that paper, I discussed how you could apply this particular design to the problem of finding out whether falls risk screening tools actually have an effect on falls in hospital wards. And lo and behold, a few years later, Joe Gillett and a team from Peninsula Health managed to do this and published recently as trial finding that falls risk score removal does not impact patient falls. If you need to find out more information about stepped wedge designs, I'd recommend this reference as well, because it does talk about how they relate to cluster randomized controlled trials and the levels of evidence that you'll generate. So what do consumers think of this? Well, we've conducted a qualitative study where we've got community-based older adults. We showed them a video helping them to understand disinvestment and research processes, and then gave them the example of removing bed alarms from usual care practice so that we can evaluate whether they work or not. They said some things which were not in favour of doing it. For example, they said bed alarms address a need. Whether it actually is effective in addressing the need or not, they didn't specify. Being a patient in hospital, you don't like hearing the alarms going off all over the place, but it is necessary to have some information. Again, the connection between whether it's effective for addressing the need or not wasn't something that they commented on. Other participants were quite muddled by the whole concept of disinvestment, while others were much more in support and understood concepts such as opportunity cost and the need to justify the use of expending resources. Now, when we think about some of our key uncertainties, when we look at the studies for bed alarms, we know that the Wolf study was actually very small and only had a small number of participants involved who actually fell. Also with the Shaw study, there was a control condition that actually had alarms being used. It wasn't being compared to no alarms. So when we compare the dose of intervention to control, if it's on the wrong point of the dose response curve, it may not detect something which could be detected if it was done elsewhere on the curve. So in the Shaw study, they're actually comparing 1.8% alarm use to 6.4% alarm use. What was missing was a no alarm use condition, a third arm. So we've got a new problem. We need 3 arms. Now, previously, when I've used 3 arms in a stepped wedge design, we've got a problem in that we couldn't compare the grey condition to the white condition fairly, and you end up not necessarily in a disinvestment condition. So you actually need to do a secondary disinvestment to find out whether the findings from the research are sustained. So this new design that we've come up with is a concurrent multiple group disinvestment stepped wedge. It looks much prettier, it's got more colours, but it allows us to compare the conditions fairly. It ends on one of 2 disinvestment conditions, meaning you don't need another disinvestment to translate it into practice. Now, this study that we're doing is actually a study within a study, because we're using this research design to figure out whether the people who are involved in this study are more likely to translate it into practice than similar wards that aren't involved in the study. So the study itself is this red box, and there is a much bigger study that it sits within to figure out what is going on. Now, this is, of course, a big team effort. There's a lot of researchers involved and a lot of different health services involved so far, but you could be a part of this team, because we are now looking for people interested in doing PhDs and also for sites to be in our matched control arm, where we will provide them with the results of this research as soon as it is prepared. And we want to see whether those control sites change practice as much as the sites who are actually involved in the research, because we think that being involved in the trial might actually help people to change practice more easily than if you're not involved in the trial. So if you're interested in either of those opportunities, please give me a call. Thank you.
Thanks. Thanks, Terry. Sorry, I'm just having, I'm muting and unmuting myself at the same time. We've got a few questions in the chat, and I'm just trying to sort ones that are probably going to be most appropriate for you. There's a lot of questions about falls risk assessments. Do we think they make a difference? And also, do we think they need to be more specialised for specific areas?
Yeah, good question. The United Kingdom has been on a process of trying to remove hospitals' falls risk screening tools, particularly the numeric components of screening tools, where we're trying to quantify some sort of falls risk for several years now, and they've succeeded in reducing, I think, the number of trusts over there by about 50% that are actually using these tools. The study from Gellet et al. Provided randomized controlled trial level evidence that it has no effect on falls when you remove these tools. There's some other work that has recently been published in the Journal of the American Geriatric Society that Meg Morris has led and has produced a very similar result. So we're actually looking forward to potentially being able to pull those sorts of studies together to get really narrow confidence intervals around the answer to that particular question. But until we do that, I guess at this stage, we've got a couple of randomized controlled trials saying that if you remove the numeric falls risk screening component, it doesn't affect your rate of falls, possibly might even be a benefit.
Thanks, Terry. So what we might do now is we will have a short break until 10:15 for people to stretch their legs and go and grab a cup of tea. And then we'll come back after that. And again, for people that are putting questions in there, we'll try and cover these things in the panel discussion, and anything that we don't cover in the panel discussion, we'll try and pick up after the workshop. So we do see your questions and they will be answered at some point. Thanks very much. See you all in 5 minutes. Okay, welcome back. I hope everyone had a bit of a chance to stretch their legs. So I am now going to hand over to Frances Batchelor. So Associate Professor Frances Batchelor is a research and clinical physiotherapist and Director of the Clinical Gerontology Division at the National Ageing Research Institute here in Melbourne. And she's also a research lead for the Melbourne Ageing Research Collaboration. Her research and clinical expertise is in falls prevention, physical activity, and health and aged care service improvement. And she's going to be talking about co-design of hospital-based falls prevention interventions, the safer and infallible projects.
We can
infallible
say.
projects.
We need good acronyms. Thanks, Kathy. And we'll work the technology and hopefully it all is going to work. Can you all see that?
Yes, we can.
Excellent. Just adjust my settings here so that I can see what I'm doing. Look, thank you very much for the invitation to present at this workshop today. Today I'm going to talk about two projects that have used a co-design approach to tackle a couple of issues around falls prevention in hospitals. Now, I don't think we'll do the poll because really it was just going to be a little teaser to the content of my talk, and just a few technical glitches might mean it's a bit too frustrating. So we will just head straight into the talk. So the two projects I'm talking about today have been undertaken as part of the Melbourne Ageing Research Collaboration, which is an ARI initiative consisting of 18 partners across aged care, hospitals, advocacy groups, universities, and it's supported by the Victorian State Government and funded by the Wicking Trust. And our aim is to improve the lives of older people across 4 key areas: dementia, mental health and wellbeing, end-of-life care, and of course, falls prevention. And our projects use a co-design approach to address issues of importance to the sector and importantly to older people. I don't think I need to go into any of the details about falls in hospitals, as we've had some excellent overviews of the nature and impact of falls in hospitals. But what I wanted to really talk about is the sort of clinical practice challenges. When I talk to frontline staff, you know, they're very concerned about how they're going to implement the evidence. If we look at the evidence, as Meg has presented, how applicable is that in different settings? So if a study's been done in acute and I work in subacute, does that still apply? Whose roles and responsibilities are falls prevention? Which ones work and don't work? And I think Terry gave us a great overview of how disinvestment can actually, you know, not lead to adverse events. We hear concerns about the potential side effects of falls prevention strategies, and I'll cover that in the project too. And really, people are asking, well, there might be all this evidence, there might be policies, but what should we actually do on our ward or in our hospital? So as part of the MARC program of work, 2 key issues were identified, although these weren't at the same time and not really by the same end users, if you like. But these 2 issues, firstly, the very urgent need to reduce inpatient falls, and secondly, a focus on falls prevention was tending to lead to patients becoming less mobile, are addressed in these 2 different projects. So as part of the MARC approach to research, we use co-design, and this seems to be one of the buzzwords in research right now, but often used in different ways and with different approaches and inconsistency in definition. And one of our NARI colleagues, Ellen Gaffey, who's undertaking PhD on co-design for people with dementia, has synthesised these various approaches to provide an overview of the crucial elements, which you can see on the slide. And the 2 main aspects are exploring an issue or a challenge and then generating solutions, and importantly, evaluating the solutions. But co-design also involves the end user, so if you like, from the outset. When we talk about the end user, that means staff in hospitals, patients, as well as, management. So not just frontline staff, but all hospital staff. And we recognise this is a complex system and involves more than just the patient elements. And that's what we've covered in our co-design process. So our first project was really looking at a sustainable approach to falls event reduction, with a priority being identified as the urgent need to prevent falls. And this might be familiar to some of you. In the hospital, you have perhaps a sentinel event or a spike in falls rates, and there's suddenly renewed efforts to roll out a falls prevention, program. So what we did with this particular project was we worked with 2 health sites who had wards that had particularly high falls rates. And what we analysed was a very complex set of rich data in a limited time period so that we could provide information back to the staff on a number of elements. So it was detailed falls information when falls had occurred in a 10-week period. We wanted to know what staff knew about falls and their perceptions. We wanted to know what patients knew. And we also wanted to look at the particular environments specific to those wards. Once that was done, all that data and information was collated and fed back to frontline staff. And we conducted a co-design workshop with them so that they could identify priorities for action and select the strategies to implement, which are evidence-based wherever possible. And then these were implemented at each site. And we had an evaluation of the impact of implementing those interventions. And in true sort of co-design, this would circle back around and carry on, but it was within the confines of a particular project. So what we wanted to know was these 2 sites at 2 different hospitals, one an acute unit, one a subacute unit. On the surface, they look somewhat similar and they had a similar patient profile. But what did the falls information and all that data we collected tell us about, the very nature of the falls that were happening? And what we found, both had very high falls rates. On site 1, 29% of falls resulted in injury across that 10-week period. The majority were not overnight, whereas on site 2, 80% of falls happened overnight. In site 1, we had people who were walking or standing, not waiting for supervision, whereas at site 2, 75% were falls from a bed or chair for people with cognitive impairment. So we had quite a difference in, I guess, the profile of falls at these 2 different sites. So in site 1, it was people who were getting up and about and not waiting for supervision, and generally not necessarily cognitively impaired. And at site 2, it was generally people who were less mobile, had higher rates of cognitive impairment. So you can see with this information that strategies that might work at site 1, for example, patient education that Meg talked about, are unlikely to be effective at site 2 because of the rates of cognitive impairment. So different strategies were required. So in the co-design process, the ward staff, so nursing, allied health, medical, pharmacy staff, occupational therapy staff, at site 1 selected that they wanted to focus on upskilling staff in assessing risky behaviour and patient education. Whereas at site 2, they wanted to focus on providing more constant supervision and involving all staff in falls prevention. The strategies they chose, interestingly, was some disinvestment, so removing falls risk signs because every patient had a high falls risk alert, but then assessing patient behaviour. So does the person know they need help? Will they ask for help? And will they wait for help? Whereas at site 2, they created a no falls zone, so an area for more constant supervision, and implemented incidental intervention for all staff to address patient needs. And then they implemented the strategies. And I guess what we've learned is that you need to consider barriers and facilitators to implementation in a systematic way, and we're probably just really at the journey of finding out about that. So probably wasn't done as well as we could have. And what we saw in terms of the results was a large reduction in falls rates at both sites. In terms of the implementation, however, there were some differences. Site 1 managed to implement all their strategies to a high level, whereas Site 2 had some logistical issues in their implementation. The trial occurred over Christmas, so they had bed closures, they had an outbreak of gastro, you know, all these very real world considerations when making changes and implementing interventions. So we can't say that the reduction was a direct result of the intervention, but we could tell that the profile of falls and fallers had changed. So in Site 1, falls were no longer happening in patients who should have waited for supervision for walking, and Site 2, falls were no longer happening in the overnight time slot. So really what would need to happen from this is another cycle of data collection and strategies implemented based on that current data. So not just continuing to add strategies, but refining those strategies based on the local information. So the second project, which I'll briefly touch on because we don't have any hard outcomes yet, is our Innovations to Prevent Falls Through Mobility project, the Infallible project. And this was really identified from frontline staff who had had a big focus on falls prevention, but they were starting to feel that this might be detrimental to patients. For example, mobility was declining because every time the chair alarm went off, a nurse went in to say, you know, don't get up, sit down. And they were also really concerned that keeping patients, you know, from moving too much was increasing their falls risk after discharge and so on. But they didn't really have any particular hard data to back this up. So what the aims of the project were to maintain or improve patients' mobility in hospital at the same time as preventing falls, and at the same time as maintaining mobility post that discharge period, and also not exposing people to that increased falls risk that can happen after discharge. So again, we undertook this research at 2 different sites. One was a psychogeriatric unit, and the other one was a geriatric evaluation and management unit. And in a similar approach to the SAFER project, we used a co-design approach, this time also involving a consumer representative. We understood the initial problem, but we had to further define the scope of it and look at current practice, including understanding whether there was even any data collected on mobility at admission and discharge, which we found wasn't occurring in the psychogeriatric ward. So again, we looked at those sort of 4 different aspects: patient, staff, systems and environmental components to help us to understand and define the problem. This was fed back to each site, and they co-designed their priorities for action and selected the strategies, and most importantly, this time looked at the barriers and facilitators to implementing those strategies. And obviously then implemented the interventions, and this was over a 5-month period. And just to give you an idea about the differences between the 2 sites, so we can see the mean length of stay in Site 1 in this baseline period was 34 days compared to only 10 days in Site 2. So you can see there's much less window of opportunity to make a difference at Site 2. And we also have quite a different profile of functional abilities of the patients at the 2 different sites. And a relatively, I would say, low level of staff confidence in their ability to actively promote mobility. And that mainly came from the nursing staff feeling like they didn't have confidence to promote mobility. So this data informed their co-design. And we found differences in what was selected, obviously at each site based on their data. So at Site 1, they were planned to use an environmental triggers, as well as developing a ward routine of rest time followed by mobility time, and some environmental triggers such as signs, staff wearing runners to promote an active kind of environment, and an indoor walking track. Whereas Site 2, who had a much less mobile population, and people who may have required a period of non-weight bearing, there was a decision support tool for nurses to lead exercise on the ward when they had the time and through incidental and both planned activity. And this was supported by all staff, as well as engaging our family in exercise. So we don't have the results of that study yet, so watch this space. But I guess I think the implications for clinicians is that we need to make use of our local evidence that's available. So what does the data on your ward or in your workplace tell you? Do you really use that data? Do you collect enough data? Do you have information, a rich set of information without adding too much to the burden about the differences in particular wards, for example, at your health service? You need to consider how the evidence applies to your setting, and that sometimes what seems like a good idea can have unintended consequences, such as functional decline. And I think we need to further, I suppose, deepen our sense of person-centred care, and that perhaps standardised interventions and a one-size-fits-all approach doesn't necessarily work. And that rather than having a standardised set of interventions, maybe we need a standardised approach that consists of that local data collection and responding to the very unique context within individual wards and health services. And I'd just like to acknowledge all the project team members for both the Safer and Infallible projects. Thank you.
Thanks, Frances. Just get my video back on. Now, we are running just a little bit behind time, so we might just move on to Keith. And there are a couple of questions for you in the chat, but we might pick up on them in the panel discussion. So I will hand over to Keith Hill. So Professor Keith Hill, again, and I'm sure he's well known to many of you attending today, is the director of a new research centre at Monash University, the Rehabilitation, Ageing and Independent Living Research Centre, or the RAIL Research Centre. He's a physiotherapist and senior researcher with extensive research experience in falls prevention across community, hospital and residential care settings, and also looking at transitions in care. So I think we are starting off with a poll presentation, a few questions for Keith, which the first question is, does moving a high falls risk patient's bed position within a ward or changing the ward have any effect on falling? And it looks like we've got a lot of responses, and it's full, and everyone there's a resounding yes to that it does impact their falls. And the second question is, if a person with dementia is admitted to the ward, I've just lost part of the question there, and they bring in a walking aid, you'd routinely move the walking aid out of their reach so they don't get up by themselves. So again, and that's still changing around, and the poll's full. So most of you wouldn't routinely move the walking aid. And on that note, I will hand over to Keith.
Great, thanks, Kathy. So the focus of my presentation, just waiting for that to go to full screen, is on particularly focusing on the subgroup of patients with dementia. I do want to start by just saying, you know, this is an extremely challenging setting for falls prevention, and it relates to why we've got far less research in this setting. So things like short length of stay, staff variability, patient status changes very quickly, that complex mix of acute and chronic health problems, environmental a different environment and routines. All of these things make a substantial challenge to what we're doing, and in some way we need to address some of these if we're going to be successful in what we do. But the data that's been talked about earlier, and this is some UK data that just shows that in the hospitals, there were, in 1 year in the UK, there were 26 patient deaths, 530 fractures, and over 1,000, hip fractures and 1,000 other fractures, shows that there's a long way to go to reduce the magnitude of this problem. This slide just shows you where the research evidence in falls prevention is, and the Cochrane review for the community here is from 2012. We don't have, and we won't ever have, another one in the community that brings together all of falls prevention. It's just too much research. There's now a recent exercise in the community setting Cochrane review with over 100 randomised trials. But in 2018, the hospital Cochrane review, 24 randomised trials. So we're a long way behind in that setting. I do want to also just mention that we need to think about both ends of the hospital setting in what we're doing, the emergency department for those who are discharged home and also for those who are admitted. It's a gateway, and it is where some falls can occur in what we do from that emergency department presentation. So that needs to be part of the equation. The other part is at discharge, 15% of older people will fall at least once a month after discharge, and about 11% of those will have a serious enough injury needing to go back into hospital. So we've got to do better in preparing patients for discharge. So if you look at the Cochrane review, which is thought of as the gold standard of research evidence, we don't have great evidence in this sector at that high level of quality randomised controlled trials, and part of that is all of the challenges that we face in trying to get good quality research in this setting. But if we look just at this, you don't have a lot to go on. So from that Cochrane review, supervised exercise, bed share alarms, education programs all have the final conclusion of having very low quality evidence, uncertain about the effects. The area that has the most evidence is around multifactorial interventions, and even that it comes up just with a low quality evidence rating, but may reduce the rate of falls. But if we look beyond the systematic review, which brings together a lot of data from different studies, and there's some value in that, but you also lose some of the detail. And if you go then back to the individual studies, there are a number of individual studies, and despite some weaknesses in these studies, these were all successful randomised controlled trials that I think we can draw some evidence from. And I just want to touch on the education side. That is becoming more strong in the research evidence. But some data from Terry Haynes' study has suggested that cognitively intact patients, an education program can actually increase risk. These other multiple intervention studies down here were all different approaches that used a combination, often based on a screening or an assessment process. And the stars indicate that these ones had included people with dementia, and that's very pleasing because a lot of studies exclude people with dementia. So we do have some evidence in there, but you've got to go down below the Cochrane review level to get to some of that. So are falls a problem for people with dementia? Well, they very definitely are. Older patients in hospital have about twice the rate of falls as those who don't have cognitive impairment. Another challenge is that many of these falls for people with cognitive impairment are not witnessed. So we don't even have the circumstances of fall often that we can talk to the patient about that gives us some valuable information. In the community setting, about 50% of people with dementia will fall in a year. So that's nearly double the rate of falls for people, older people more broadly. And if we think about the evidence in falls prevention in hospitals, I talked to you more generally about the falls prevention evidence, but if we look at what is there in that is specifically tailored to people with dementia, there's much, much less. And this is a fairly recent review, Stockwell Smith 2020, that looked at in-hospital falls interventions for cognitive impairment. It did use a mix of studies, and it only found a very small amount of research to include in the review. You can see one randomised trial, a step wedge trial, 5 pre-post studies, time series, and repeated measures. So it's a bit of a hodgepodge of methodologies, but they brought together what there is in this space, and they come up with a synthesis of some of the key elements they feel that we should put in place for our patients with dementia in hospital. The 5 themes were: engage with families in falls prevention, assess falls, identify interventions, extend nursing observation through technology, conduct a medication review, and initiate non-pharmacological delirium prevention interventions. So those are things that have come out of this small subset of studies of varying levels of evidence that I think can be used to guide what we do in this space. Now, we've heard about bed chair sensor alarms and the Cochrane review that suggests these are not effective, but they're still very widely used. One of the things that I want to highlight to us as a group is that we shouldn't throw the baby out with the bathwater with some of these things. And so not all sensor alarms may have the same problems and have the same outcomes as the current bed chair sensor alarms. And so we've been working with a group in Adelaide, led by Professor Renuka Viswanathan, a geriatrician, and Associate Professor Damath Ranasinghe, who's an engineer, developing a different sort of sensor technology, had some small grants, and ultimately ended up with a large NHMRC grant to evaluate this new system in 2 hospitals in Adelaide and Perth. The study is complete, but we're still finalising the analyses and the publication of results. I can't share with the results today. This is the nature of the system. It involves the patient wearing a singlet, and in that singlet is an accelerometer in a pocket over the sternum. There are readers in the roof that monitor the sensor information, the accelerometer information, and add also other valuable information to what the accelerometer itself is giving. The nurses use a mobile phone and can be on vibrate or on a voice alarm on the ward for the sensing of the alarm going off. And it's an intelligent system, ambient intelligent geriatric management system, in that it can be tailored to individuals. So it can be have an attachment to a gait aid. So if a person's not meant to walk without a gait aid and they start to move away from a gait aid, that can set off the alarm. If they're allowed to walk in the room but not out of the room, it can be set for that, and so on. And so it's somewhat different, and hopefully, you know, it gives us some direction, and there's a lot of developments still going on with it, and we might be able to get preliminary work to get substantially more accurate than the existing bed share alarm. Also, just want to touch on bed moves. Bed moves are a very common event in hospital, unfortunately now. They're defined as any move from one bed to another in a room, between rooms, or between wards. We did a study looking in an acute hospital in Perth at patients who were admitted with high risk of falls. So a screening tool was used in the ED, and those who were high risk were followed through their journey. They had a median of 2 moves, including the move from the ED. One poor patient had 8 moves, and you can see a little bit of an image of that at the bottom of this slide. This patient had 7 moves in a 26-day episode of care. That is not, I cannot see any time where 8 bed moves would be justifiable. Certainly there may be times where we do need to have some bed moves. Bed moves occurred throughout the day and the night, and obviously bed moves at night will be very disorienting for an older person and or someone with cognitive impairment. And the key finding here was that every bed move increased your risk of fall by 56%. So these do change a person's falls risk. We do in hospitals. So bed moves are common. They are associated with increased falls. And so what do we do here? Well, we need to think about, is this bed move essential? And if it is, are there other patients with lower falls risk? We just looked at high falls risk patients, but Could a move of a lower falls risk patient solve the problem that's needing the bed move to occur that might have less of an impact on falls? And if a bed move is essential, then staff need to know that the patient is at higher risk in that period after that move and adopt higher vigilance. And in fact, the patient needs to be informed as well. Another aspect, and this was a little bit of the prompt on the poll at the start, was around walking aids in hospital for people with dementia. There's generally confusion about whether people with dementia can safely use gait aids, and that's in the community as well as in hospitals. Inconsistent decisions are being used about using a gait aid for someone who is unsteady. Normally for an older person who's unsteady, it's one of the first things we would do. But people are reluctant in some cases to administer a gait aid for an older person with dementia. And anecdotally in hospital, there's some evidence that gait aids are removed from an older person who has used a gait aid at home. They've been safe with a gait aid, but the gait aid is removed when they're in hospital because we don't want the person getting up without supervision. But removing the gait aid usually does not solve the problem, and the person will get up when they want to get up, a person with dementia. So we're currently investigating this with a study at Monash by Angel Lee, looking at current practice in hospitals, community care and informal carers, developing a decision support tool for gait aid use and piloting a training program for people with dementia. So that's just a very quick snapshot about what's probably the most difficult practice and research area in a very difficult practice and research area. So dementia falls into people with dementia within the hospital setting. So cognitive impairment does substantially increase the risk. There is some differences around what works for cognitively impaired and cognitively intact in patients in some instances, and that's the patient education in particular. So it's not a one size fits all. Some successful individual randomised trials have included all ward patients, and that's very positive and a place where we can draw some good findings from. And we need to think a bit outside of the box with respect to what we're doing and look for innovative and new approaches, one of which may be the sensor approach. Thank you.
Thanks, Keith. Sorry, I'm just getting all my things back up again. And I think that really, covered off on a lot of areas that are certainly concerning to clinicians working in the area. So that was fantastic. Now, we are now going to move on to the panel discussion section of today. Now, this is probably running a little bit differently to what we originally planned, simply because of the number of people that are attending. So most of you will have, well, hopefully most of you received a pre-workshop survey where we asked you what some of your concerns and some of your challenges were and what some of the things were that you want to know. From that, we've actually curated a list of questions that really cover off on the most frequently asked questions or concerns. And really that's so that we can, with such a large number, it's actually would be quite hard to moderate the chat group through the whole panel discussion. However, you can keep putting, I've added to the list based on some of the chat questions and that have come up during people's presentations. So we will throw a few extra in. And certainly if you have other questions, you can keep adding them in. If we don't get to them today, we will try and get back to you after the workshop. Now, the other thing I would like to do is welcome a couple of new people to the panel. I'd like to welcome Dr. Ron Leong. Dr. Ron Leong is the Deputy Head of Aged Care at Alfred Health. He's trained as a geriatrician and rehabilitation specialist. So welcome, Ronald. Hi. And we are also meant to be having Jackie Kay, but I can't quite see her on my screen at the moment. So she may join us. I will introduce her just in case there's a little glitch, but Jackie is a physiotherapy team leader in general medicine and aged care at the Royal Melbourne Hospital in Parkville, Victoria. So I think, have we got the slides, Kathy, that we're going to pop up just to show the first question? Otherwise, I will, here we go. So the first question we're going to be addressing is, I suppose, a bit of a hot topic in terms of what do we think our falls goal should be for hospital falls? Should we actually be aiming for 0 falls, or should we be aiming for just as low as possible, and what might that be? And how do we balance this with respecting patient needs, preferences and freedoms, and ability to meet rehabilitation outcomes and resource limitations? So double-barreled question. I might throw first of all to maybe Frances. Maybe have you got some thoughts about what our goals should be, and how do we balance these competing issues?
So I don't think we should aim for 0 falls. Don't know if that's controversial for some people, but you know, we are all inherently at risk of falls because we move in the field of gravity. And so, I mean, people do still fall out of bed, but if we aimed for 0 falls, I do think that comes with a concomitant risk of limiting people's ability and choice to move. So I think we have to get a lot better at working out that balance, and also involving patients and their families in determining the level of risk that they can tolerate.
Thanks, Frances. Ronald or Jackie, do you have anything to add for that from a clinician's perspective?
Yeah, sure. Thanks for inviting me. I think we've grown up through falls, and many on the panel here have obviously spent decades researching in falls, and I think we have found that the message has changed over time, of course, and that, you know, we've gone from all falls are preventable and to maybe some falls are preventable and some are better at harm minimization. So I think I agree that going to 0 is not, I mean, it's a matter of how many resources we have to implement and how much restrictions we're going to implement on our patients to restrict their movement. I mean, if we held someone in a chair, they would not fall, but they will have other injuries. So they would certainly be, certainly deconditioned, have pressure injuries, and etc. So I agree that we should obviously have a way of looking at falls that hopefully reduces harm as much as we can in a hospital environment.
Jackie, did you have anything you wanted to add there?
Hi, sorry I'm a bit late. Thank you for having me. Yeah, I agree. You can't have 0 falls. I've had patients that have literally dropped when I've been right next to them, and we know that people still fall when they're one-on-one nurse specialed over a 24-hour period. So it's just not possible, and I think it promotes a fear within our clinicians to have everyone just stay in bed and stay in the chair, and if they don't get up, then that reduces the risk, and that's just has far bigger impacts, I believe.
Thanks, Jackie. And Margaret, I might put you a little bit on the spot here to give what your perception is from a patient perspective, because obviously this is a risk-benefit question that really, at the end of the day, it impacts on patients.
I don't think you can look at no falls occurring in the hospital setting. We've each got to live with some element of risk in our lives, because without being able to move around with relative freedom, I think older people would still feel that life was diminished in its quality, and that would be my perception, that we have to accept a level of risk no matter what we do in life.
Yeah, and I think it picks up really nicely on the point you made in your presentation about how you felt it was, you know, you actually felt quite demeaned with having bed rails up and things. You felt it restricted your mobility, your independence.
And I think too that the one size fits all that I think Frances made the comment on is quite right, because again, I know when I've watched Susan Curl's ABC presentation with the older people and the 4-year-olds, that, you know, there's enormous awareness of risk in that older age group. I think it's probably the 65 plus that might be a little bit more
shall we say, not prepared to accept the education.
And I can see Keith's got something to weigh in here. Go for it, Keith.
I think a target should be a no or a low number of falls where in our post-fall review there wasn't something else we could have done to avoid that fall. So in some situations that won't be the case. We have done everything we can do that we should have done, and that we have to accept that, and some of that's around patient choice and so on. But it's the concept of nurse huddles was touched on. I think that's a very good approach, but a detailed review of what caused a fall, and in particular prevent the next fall, because something we haven't mentioned is that there's a pretty high proportion of single fallers who go on to become multiple fallers, and we really should have our alarm bells on once someone's had a single fall in hospital.
Thanks, Keith. And Meg?
I was just going to say that, Keith, that certainly what I found working not only at HealthScope but across all of the different hospitals is that certain patients are frequent fallers. And once a person's had one fall in hospital, they're at a really high risk of having a second or more falls. So I think that, we should really focus on those ones that are particularly high risk with them, multiple factors, but also those who have just had a fall. And really, I think we should be able to prevent most of the second or recurring falls in hospital.
Thanks. So it sounds like, no falls is probably not achievable, but we need to have work on no preventable falls, and also really focus on reducing those second falls. We really need to make sure we look at what we can do to prevent those. So we might move on to the second question. And I'll give Jackie and Ronald a pre-warning that I'm going to ask you this one first. So who do you feel should be responsible for promoting the safety of patients in relation to falls in hospital? And who do you think are the staff that get blamed if a person does fall?
I think this is probably an easy one. I think everyone should be responsible for the safety of patients. Nursing, everyone should be alerted when there is a high falls risk patient, although I understand that on some wards, particularly the one I work on, is everyone can be a high falls risk. And then I think, unfortunately, it's nursing that often get the blame. They're the ones that are left with the patient. They're somewhat responsible for the patient's care around the clock, and that can be really, that's really unfortunate, because it really is such a team effort. I mean, we know how many risk factors are involved with falls in hospitals, so it just can't be down to one profession or one person. It has to be everyone involved. And I would pull the patient and their carers and families into that as well.
And when you're talking about everyone in terms of hospital staff, do you think the focus should be predominantly with clinical staff and health professionals, or Margaret touched on earlier about the importance of including ancillary staff in that? Do you think that's something we do well enough, or is that potentially an area we can be improving on?
Definitely. I think some of the ancillary staff who are in the rooms when others aren't need to be empowered to speak up if they think that something's not quite right, or the patient looks like they might be about to have a fall, even if they're not trained to do that. And I also think, I know Meg talked about the executive and the policies and things like that. So that really is really important as well, to have the higher level staff in the hospitals involved and interested. I read someone had said in the chats that it's just gone down in terms of priorities, and probably over the last year in hospitals it's been a high priority on infection control and keeping people separated and things like that. So it needs to come back into the limelight, I think, as we progress into this post-COVID world.
Thanks. Ronald, did you have anything else you want to add to that?
Oh, I agree. It is everyone's responsibilities, clearly, and unfortunately, as you say, Jackie, the nurses do unfortunately get the blame, and often from families, mainly because they see nurses all the time. And of course, nurses are in fact the people that provide most of the care of a patient in the hospital, and unfortunately, that is the unfortunate nature of culture, I suppose, blaming someone for event. It clearly needs to be a systemized approach to these types of falls and injuries. It could be that the nurse might be so busy that they did not have time to respond to an alarm, for instance, and so we need to work out why that happened in that setting. But I agree, it is something that we have to take on board. I tell medical students that if they're walking past someone who is looking like they're about to fall, you shouldn't ignore it. You should actually approach it. Just because it's not your patient, inverted commas, doesn't mean you don't actually look after that patient. So I think it is something that we all have to take on board.
Thanks, Ronald. So we might move on to the next question. And Meg, I'm going to tap you on the shoulder first for this one. So if one of your parents or a loved one was in hospital, based on the evidence, what are the falls prevention strategies that you'd really like to see in place for them?
I've recently been in this situation myself, so it was interesting for me to be the daughter of the patient in the hospital. And what I would have loved to have seen is a conversation very early in the piece, not only with the patient, but with the family members as well, because with my family member, we were very aware of the types of falls that he'd been having over the previous year, when he fell, what time of day in particular, what were the triggers for his falls, and what he could be, how you could prompt him to prevent his own falling. So we would have loved to share that with the physios and nurses and the doctors, the knowledge that we brought to the hospital with us. And my father was even saying things like, oh, what I normally do is, and there was a little bit of a sense of not listening or not engaging with the patient themselves and the family early on. So I would love to see those conversations, to stop, to have the time to have the conversation, to listen to the conversation together, we work out a plan.
Thanks for that, Megan. I'm sorry that it was meant to be a bit more of a hypothetical question.
Oh,
I hadn't realised that we were going to get such a lived experience. But thank you very much for sharing that with us. Does anyone else have any other thoughts? Yes, Terry and Keith and Allison have all got their hands up. Let's go, Terry first.
Yeah, I just want to raise and echo Meg's thoughts there. When we've done the patient education research work, yes, we've had very structured behaviour change education strategies we've set out to do, but quite often it becomes just a conversation with patients about the issue, and that it becomes something that creates an opportunity for the questions to raise their concerns, family members, if they are there, to share their insights. So you read the education papers, the ones that I've been involved in, running, we've had structured patient education based on behaviour change theories, but do not ignore that very human element of just establishing a relationship, establishing trust, and being able to create a shared space where people feel free to discuss these issues.
Thanks, Terry. I'll move on to Keith.
Thanks, Kathy. One of the other things that I'd like to see in place is standard falls prevention activities, and these are very basic things that in the Australian guidelines that have been mentioned in a bit of the chat from 2009. They did have a list of things that every patient should have, and they're just very simple things that remove clutter around the bed, call bell within reach, and so on. We did an old study quite a few years ago now in acute hospital, and we went in and did a surprise audit on some of these basic activities, and found very low levels of compliance with them. So there was a lot of clutter. Call bells often weren't within reach. And we then made clear that we were coming back to review in each week, and all of a sudden the presence of these best practices was occurring much more. We shouldn't need audits. We should be able to get that practice changed that a few of the people have been mentioning. But these are very simple things, and if they're not in place, falls are going to occur. So we need to have that as a basis for my parent when they go into hospital, if they go into hospital.
Thanks, Keith. Allison?
Thank you. I would just, I guess I'd like to reiterate what Meg was saying, but particularly thinking about the person with cognitive impairment and the importance of talking with the family, because the family know the routines of that person. And I can give another example of one of my parents who had repeated falls in hospital, and this was my father, who had some dementia. I knew that I knew his routine. I knew that he would wake up in the middle of the night. I told the staff in the ward that he would wake. He wouldn't remember that he was in hospital. I knew what side of the bed he'd get out of, because that's the side that he slept on. So I knew exactly, and I knew that the bathroom was on the other side of the room, so that he wouldn't realise. He would negotiate his way around the end of the bed, but and have to get to a bathroom, but he wouldn't actually be aware of where he was necessarily. And of course he fell in the middle of the night getting up to the bathroom. And again, the following day I said the same thing. He will want to get up to the bathroom. He won't remember where he is. He won't use the buzzer. And again, he had another fall. So I think with 3 nights in a row, he had falls on the way to the bathroom. So it was, but I guess I had the opportunity to say that, but it wasn't heard, and acted on. So yeah, the family, it's just so important to listen to them, and particularly with a person who is cognitively impaired.
Thanks, Alison. And Margaret?
Look, I think it's been fairly well covered, but the point that I'd like to make is that when the family talk to the nursing staff, say on admission, it needs to be conveyed to each change of staff, because it's fine to sort of talk to the person that's in the room when you first arrive, but then through the night and through the following morning, there's different staff.
Yeah.
And if they don't have that information conveyed to them adequately, well, it's almost useless anyway.
Thanks, Margaret. I think that's a really important point. And I think the other point that came up in this discussion is that even though, a lot of the researchers and academics are here because of our research and academic experience, it actually is still a very personal experience for all of us. And it really is a personal experience for everyone in this forum, because we all have loved ones who are going to be at risk if they go into hospital, and unfortunately you never quite know when things are going to happen. So Alison, I'm going to throw this next one to you. So we know hospitals are really busy places, and we also know staff are really busy. So what do we think can be done to minimise burden on staff? So what do we think we should be stopping? What falls prevention practices should we stop? And what practices might we need to do a little bit more research into?
Yeah, really good question. I guess we've talked today in previous sessions about a number of interventions that we use that we actually don't have really good evidence for, that do take a lot of time and do require, and it can be very expensive because of the time. And also the equipment. So we need more research to understand whether those interventions are effective or not. And for those that we know are not effective, and Terry's example with the falls prevention alarm systems that are widely used, whether we disinvest those sorts of interventions, and the resourcing that goes towards that currently can then be used to support other effective resources. And there are things like a lot of time gets spent on doing routine assessments and documenting them, and Keith talked about, having a fundamental set of interventions that are applied for everyone, and so there doesn't need to be that time spent on doing all those assessments. It's just those interventions getting put in place automatically, and so that also would save time.
Thanks, Alison. I'm going to throw to Jackie and Ronald again, because you're both clinicians working on the ground in hospitals. So what do you think can be done to reduce staff burden in this area, and are there things that we should be maybe stopping?
I'll jump in first, sorry, Ron. I think the environment, it's come up so many times this morning already around how you can structure an environment to make it safer and more friendly towards particularly the older patients. There's a lot of emerging literature about how you should design a hospital and how that can be used to effectively mitigate some of these risks. And so I just think some of these things are really easy, and it's about clutter and hallway space and things like that that can really reduce the risk. But also having gate aids and things close by, and not having the call bell on the bed when the chair is away from it, little things like that. And also things like not locking tray tables in. I know it seems like it's saving time because it gives a nurse potentially time to get back into the room. But generally people are trying to get up and get going, particularly if they need to go to the toilet. And it's like, I could go on forever, sorry, I won't, but it's like having the crash mat next to the bed and having the bed all the way down to the ground. People will try and get up. So, it's how do you reduce the risk as much as you can, but enable the person to move, and that's the physio coming out in me.
Yeah. Frances?
I was just going to say, as a resource there, NARI developed a hospital environment audit tool on behalf of the Victorian Department of Health, and that's freely available on the website. You can Google it under Older People in Hospital resource, and it contains modules that you can do just in terms of a bedside audit, so very practical things that you can do, and not necessarily you don't need a lot of money. It's really that day-to-day audit as well as the broader facility audit. So I think that's a really good resource for health professionals to look at.
Thanks, Frances. And I can see someone's asked for the link, so we'll make sure we get the link through to you. Keith?
I have some different opinions to some of the others in the room.
That's why we're having a panel discussion, Keith.
It might be because I'm old-fashioned or what, but I do feel that, for example, falls risk screening or assessment could be still part of what a good falls prevention program has, despite some evidence that by withdrawing these things that we don't change falls risk. I'd ask, are those tools being used well and appropriately when they're being withdrawn, or are they just tick box exercises? Because when you do those things, they're of no use if you don't follow up. But basically, there are two things you can do in hospital. One are general interventions, a bit like what we've talked about with just safe environment and so on. And others are personal ones that relate to the individual and their own risk. And unless we know in some way, and it might be falls risk assessments, but it might be a comprehensive geriatric assessment. One of my concerns is we do too many assessments for all of the different things, and there's a lot of commonality on them. But some way we need to know what are the key things about this individual that's going to make them more likely, and is there something we can do about managing that as well as the general things. So there's a lot of questions in all of that. I don't have the answer. I don't have the whiz-bang tool and processes that follow on from that. But I'm just saying that I feel there is a place for somehow knowing the individual person's risk.
Thanks, Keith. I'll quickly throw to you, Meg.
Yeah, so having just done the big trial that we've just got published last week in JABS, fantastic, in 10 hospitals across Australia, what became clear to me was that we've got FRATs, which is falls risk screening tools. Like there's screening tools, and some screening tools have numbers, like assign a risk rating 1 to 10. It's very clear to me that those scored FRATs are not beneficial. And then you've got assessment. Like for some people, there is a need to do a detailed assessment, but that should be targeted. You don't need to assess every single thing, but target your assessment to the patient's age and their needs, and make it very goal-directed is what I would say. So again, I agree with your point about don't throw the baby out with the bathwater. I think scored FRATs are a bit of a waste of time. It's possible that some FRATs that don't have a scoring system that are very quick and just give you a bit of a prompt and a cue might be helpful, but the evidence is that clinical decision-making, nurses, allied health, doctors are really great at clinical decision-making. assume that every hospitalised patient is at risk of falling, especially those over the age of 55, and then go straight to your assessment in a targeted way if needed.
Thanks, Meg. Now, Francis, I'm not sure if your hand's just left up or if you've got something else to say, but no, nothing else to say, so we might move on. Actually, I will just quickly throw back to Meg, because we did, there was some discussion about non-slip or grip socks, and I know you did flag your systematic review, but can you maybe just give us a quick soundbite for people that want the answer before they have to read the systematic review of, is there evidence to support their use at the moment? Or would you use them?
I've already sent out the links. Thanks for all the emails, everybody, and I've sent you out a copy of the paper. The paper is coming out hopefully in the next 2 weeks or so. What we found in that systematic review that was led by Dana Jazzarieri and all of our team members was that grip socks, if I call them those, there was no evidence of a definitive benefit of grip socks for preventing falls. And there was evidence of risk in some patients, in some hospitals, of infection. So it becomes an issue of balancing out what are the relative risks of infection versus the potential benefit of preventing falls. And the literature indicates there's probably many other better methods to prevent falls than putting on grip socks. And they're expensive as well.
Cost of socks as well, again.
Is substantial. Yeah. Infection risk is a consideration. So on balance, I would say go to something else.
Thanks, Meg. So we'll now move on. So Keith, I'm going to throw the next question to you. So what do you think clinicians should be doing if we have a very high risk falls patient who's impulsive or cognitively impaired or confused? What would be your key interventions?
I have covered some of the things that I think are important in presentation, even though there's, the level of evidence in terms of doing them, in terms of, for example, changing our bed moves practice and trying to reduce bed moves. We don't have evidence that will reduce falls. The simple thing around gait aids that I've mentioned, we may not ever have a randomised trial on that, but I'm interested to see around how much it's used and what are the effects of falls when that is done. High observation is something I haven't touched on, and that's one aspect with people with cognitive impairment, and it's one of the factors that's included in why bed moves occur to a degree is that a patient comes to a ward and the magnitude of the cognitive impairment and or falls risk is not understood at the time they come into the ward, and then they get moved to an area in the ward where they can have greater visibility. Another option there that I've seen in some places is mobile nursing stations, particularly for 4-bed wards where you have the patients with cognitive impairment together and have constant supervision in the room, where a nurse can be doing other activities as well as being in the room. And the use of families as well can be a very valuable resource. Those are just some strategies there that I would suggest.
Thanks, Keith. Margaret, I can see you've got something to add.
That's fine. I was just going to say what Keith said at the last, was that use the families, because I know when my late husband was in hospital, we had a session where each family member came for a number of hours and just helped the nursing staff by being there, because they just cannot keep their eyes on these people to that degree that's necessary. So ask the families if they're capable and willing to help.
Thanks, Margaret. And I think it is also just worth recognising that that's probably been something that's been particularly challenging for hospitals and health services over the last 12 months during the pandemic, where there have been visitor restrictions and, that has made things probably a lot more challenging, but hopefully we will be moving to a space where we can potentially use families more. Ronald, I can see you've got your hand up.
I just wanted to add to that.
My screen keeps flipping people's faces around, sorry.
Sorry. I was just about to say, I think I think we need to also move to a quieter ward. Wards that are quieter, they are much too noisy and distracting. And I think also we have lots of our patients sitting in a room for long periods of time as well. And I suppose having activities that might actually help improve their engagement during the day, which also will then hopefully help that sleep-wake cycle that sometimes they have problems with as well. So I think certainly those types of things would add to some of those that we could do.
Yep. So, and again, so it's part of that holistic package of management. And I suppose, again, the other thing is also looking at appropriate management of delirium. Obviously, you know, it goes without saying, but probably, you know, it's worth just remembering. The next question I'll throw to really anyone on the panel that would like to jump in. So it's, what do you think we should be doing to prevent falls in hospital as a group? So whether it's at a state level, and then also looking further down to what we should be doing at a hospital or health service level or at a local level. Does anyone want to jump in and start off with that? Maybe at a group or state level? Terry.
Thanks, Kathy. I think there's a couple of different levels that we could potentially approach this. I mean, as you can see from the chat, and as we saw from the responses to the survey before coming in, there's a great need for resources and sharing of resources out there. And I think there's a real demand for that. I also think there's a need for networking, for us to be able to come together and share our experiences, share our frustrations and, you know, challenges, to know what they are. But I also think there's a place for us to be strategic. I think there is a place for us to think, right, I don't know if you know it, but I think Victoria is has contributed more randomised controlled trial evidence to the world's literature than any other state in the hospital setting for falls prevention around the world. Victoria is the place to be when it comes to falls prevention research in hospitals. There are a number of unanswered questions. We could come together and start to, I guess, in a more planned way, a less ad hoc way than before, come together and start to really check off some of the big unanswered questions that we face, because certainly the growth in research that the world has access to, it's been the work that's come out of Victoria that's led the way there.
Thanks, Terry. Meg?
I agree with Terry wholeheartedly. I actually think we need a statewide falls collaborative, or some sort of statewide Victorian falls collaboration, where all of us, everybody at this webinar and others could be involved. I don't know about you guys, but we've got heaps of resources that we've developed at HealthScope, thanks to Rosalie Louie and all the team at HealthScope. And we're benefiting, and we've put them inside our WebEx site. But I'm thinking Victoria could have some sort of resource kit or some sort of central repository, but more importantly, you know, a plan. We need a plan so we don't all reinvent the wheel. And we need to be systematic rather than random.
Yep, thanks, Meg. Great points. Does anyone on the panel have anything else that they'd like to add? Maybe Jackie or Ronald, again, from maybe a health service or, you know, local level?
I'll start. I think the data that we have are collecting, we should try and use more effectively. I think we collect a lot of data, and some of it's obviously fed back. Sometimes it's fed back in a useful way, and other times, of course, it's not fed back in a timely way. So I think sometimes being able to use data to improve even at the local level is useful. So how we use that data across the state, I suppose, is a good question. Because I think if we had that sort of collaboration, it would be useful. I know the Health Roundtable that some of the health networks are involved in have sometimes featured falls, of course. So sometimes that's a good thing to obviously use.
Thanks. Francis?
Yeah, I think, Ron, thanks for the point about data. I think the current data that is collected is nowhere near integrated enough. It's not, you know, the multiple sources of data are not synthesised to provide meaningful feedback to clinicians, you know, on different wards. and it's sort of very high level. So you might have your falls kind of thing on the ward, which has X number of days since the last fall, but it's not providing that continuous feedback as to where to target falls prevention strategies. So a data project would be a really good thing.
Thanks, Frances. And Terry, back to you.
Do we trust the data? I think we need to be honest with ourselves with what we're dealing with here. Just because we've got big data doesn't mean we can trust it as much as what we might hope. There's a number of papers out there which do indicate that in the falls space, there are some outcomes which are not as trustworthy as others. So I do appreciate the value of big data and the availability of it, but we do need to recognise, I think, the limitations until we get better ways of capturing.
Thanks, Terry. I'll head to Meg and then Frances.
Oh, just quickly, as you know, Kathy, we've got a big project happening through MAC with Northern Health, Western Health, a range of different Melbourne Health, etc., where we were particularly interested in falls rates and how they changed during the COVID pandemic. But that's implementing some sort of macro level big data analytic techniques to sort of suck in all the risk-man data. So we've actually got methods for getting the falls data across hospitals. But what we've found out in that project is that the data that's entered in on risk-man, you know, at the ward level, seems to have a lot of error and needs lots of cleaning up. And I think quality managers often at the end of every month have this big job of going through the falls data and working out which one is real falls data and which ones have to be got rid of and so forth. I think we need to have a really close look at the data capture methods right from the ward all through to the hospital to the whole system.
Yep. Thanks, Meg, for that point. And Frances?
Yeah, no, I was just going to say exactly the same thing, that we need that granular level data that's not things that are captured in risk-man, but also take into consideration all those other aspects like the environment, the systems, the staff and the individual patients, and somehow to triangulate that, because a single source of data can't be trusted, as Terry says.
Thanks, Frances. There's data and there's other data. The next question, I'm going to actually slightly deviate from our pre-prepared questions to pick up on one that was in the chat. And this is actually about how do researchers engage with hospitals, with health staff and also with administration to actually get them to help participate in research. So again, I might first of all throw to you, Jackie and Ronald, to get your perspective from a clinician perspective, and then we'll see if any of the researchers and academics in the area would also like to contribute.
Do you want to go, Jackie?
I was just going to say I've actually find it quite easy. We've done a couple of collaborations with Mark. So Frances I've met with a few times, and it's those collaborative groups that really help us clinicians put forward our ideas, but then we get invited to be a part of the discussions for some of the bigger projects that Mark undertake across different sites. And I know a number of bigger organisations have those, but I couldn't comment on some of the smaller hospitals that would really benefit from being involved in these things. So, yeah.
Thanks, Jackie. Ronald, anything to add?
I mean, I think it's I work at Alfred Health, and they have falls on the risk register, and it's a high on the risk register as one of the things that we should try and help, which actually helps drive the research potentially, and hopefully drives interest in falls. But I can see that sometimes it is difficult to get something off the ground, and I suppose this is where it is important to obviously collaborate with people, and obviously have people like Terry come with Monash and things like that coming to help with some of the design projects that we have, of course. So, yeah.
Does any of the researchers want to comment on that, about how they think we can strategies to engage with health services or clinicians that are useful? Terry, go for it.
I think one of the things to recognise is how busy the clinicians have, and clinicians don't just have free time around to be able to just jump off and be a part of a falls project per se. So being able to lobby or apply for funding to support clinician time in research, I think is an important thing. Francis has already talked about engaging the clinicians in the design process and in the prioritisation, which I also agree with is a very important step. So getting people in at the ground floor to really understand what are the key drivers, what are the key frustrations they're facing, and what are how they prioritise, I guess, the things that we could potentially look at through research is an important thing. I mean, for me, there are processes that various networks, I'm thinking of the musculoskeletal clinical trial group, where they'll have meetings where they prioritise projects and then people can put their project sort of ideas up. Creating infrastructure to support that we could then link into resourcing opportunities might be quite useful as a means to create the resources to help clinicians have the time to participate.
Thanks, Terry. Alison?
I was going to, I guess, say pretty much what Terry had said, but I think there's been a really big shift over the last few years towards taking on a much more of a co-design approach, where researchers really do work with those that are in practice and and I think the funding bodies now are very much supporting that. So MRFF funding really requires that approach. So the questions are really the research questions being addressed are really generated from the problems that are arising in practice settings, and researchers working closely with practitioners, clinicians to design and undertake research. So yeah, I think there's been a really big shift. That doesn't take away from the issue of time and burden, and I agree with Terry. I think and funding bodies now are more supportive, I guess, of putting funding towards backfilling and enabling clinicians to be part of research teams. So yeah, that's a really important shift, I think.
Thanks, Alison. Francis?
Yeah, taking up those points about co-design, I mean, we found that there was, with both of the projects, real enthusiasm because the projects were addressing the needs that the clinicians themselves identified. And we did backfill, and we paid them for time. But also, I mean, it's just fantastic to see how when they're engaging with the data, that becomes something that is almost like an aha moment, like, oh, that's why it's important to collect data. And having that feedback loop where you've got clinicians as well as researchers working on the problem together leads to, I think, it not being a burden. And the other thing is, any data collection has to be targeted. It has to be for a short period of time to minimise that burden.
Thanks, Francis. I think your point about, making it clear to clinicians why they're collecting data is actually really important. I know as a junior physio, I spent a lot of time filling in stats about what I did with my time, and I don't actually ever really know what happened with that data. So, and it removed any incentive to actually make sure it was accurate. So we might move on now to looking at what the priorities are going forward. So, what do you see? I might start with you, Terry. What do you see as the priorities going forward to reduce falls in hospital?
I've got a biased view because I'm a researcher, so I always like to be in a job, and I'm going to say we need to do some more research, of course. We do have, as Meg indicated, and it's been indicated by others, some evidence that there are some effective strategies out there, but there's a lot of things that we're doing at the moment that we really aren't sure as to whether they're working or not, and whether they're a good use of clinician time and effort. And, you know, for me, being able to build that evidence base further, you know, as Keith said, we've got 24 trials, build that further so we can answer more of the questions, answer them in better ways than we might have already attempted to do them, is something that I think is, you know, if I want to look back in 20 years' time, I want to be looking back and saying, yeah, we're really confident now that what we're doing is preventing falls. I think the answer to the poll question I got texted through was that 80% of us were uncertain as to what we're doing in our hospitals is effective for preventing falls. I'd love to see that drop down to 10% in 20 years' time, but the only way we're really going to get there is by answering a bunch of the questions that are of direct relevance to the practice and the care that we're providing.
So are there any particular strategies or interventions, Terry, that you think we should be looking at, you know, more quickly, or as a high priority?
Well, I think there's almost an unlimited number of things you can look at, but the things that I think are high priority are things that can be easily implemented, easily rolled out, and are not hugely resource intensive. I think Keith's tapped on a couple of nice ideas in terms of patient movements and, you know, how gait aids are provided. And you don't necessarily need massive amounts of resource to introduce things in that position. I think the huddling of staff as an approach to problem solving falls, if it's something that's already being done, the research paradigms we're talking about with disinvestment now can potentially be applied to that with very little resource to evaluate whether they work or not. So looking at the things that do get done and that can be easily done, I think would be the starting point.
Thanks, Terry. So Terry's put in a plug for research as a priority. Does anyone else have any thoughts about what are priorities going forward to reduce falls in hospital? I see Meg's got her hand up.
Just picking up from the chat, I think it was Pierce just made a really great comment in the chat there about the need not only to connect allied health and nursing, but also to have really great clinician education and training programs that are evidence-based. I think sometimes what happens is in hospitals is people quickly develop a slide set and then, you know, everybody's got to do it, and that's considered to be the training. Whereas we need to use contemporary methods of education and training that are geared to health professionals who are very intelligent people, and ensure that they're evidence-based and up-to-date, and implement them in different ways that are accessible and update them regularly. So I think there's a need for this resource on clinician education and training, plus knowledge on how to best deliver it.
Thanks, Meg. Keith?
One of the things I was wondering about is around sort of a consensus statement of, you know, what is best practice, and it bringing a bunch of researchers and clinicians and administrators into the one room, because each of us have got different perspectives. If we just look at the research side, we get one set of indicators. If we look at the clinicians and what they feel like can and do and what would be valuable, you might get a different set. And I think perhaps bringing together those perspectives into this is what we expect as a minimum in falls prevention, and it may not be a lot of the rocket science stuff, but it's some of those fairly basic principles that might be useful as a starting point for everybody. I don't think we've quite got that.
Thanks, Keith. Does anyone else have anything to add to that, this question about what should be the priorities? Jackie?
I might just come in with my bias, which is clinical and physiotherapy. We need to keep people moving. We put them in a bed, we put them up against a wall, we put a whole lot of stuff in front of them, and then we wonder why they can't walk and they stay longer in hospital. We know that people take so few steps in hospital when they're here, and we supervise them right up to the second that they leave the door because we're so worried that they're going to fall or something's going to happen to them. And then we wonder why they don't necessarily cope that well at home. And I think probably the push needs to be that people move more while they're in hospital, and that's environmental and culture as well. But I think certainly something that we're looking at Royal Melbourne is trying to get people home as early as we can. So what is the risks and the benefits of having someone cared for at home? obviously money comes into it, and level of capability of families to wrap around that care. But honestly, talking about environments and things, people often best in their own homes, and they're going to do more. We know that from one of the studies I recently was a part of. So yeah, that's certainly would be my very clinical, very biased priority.
Thanks, Jackie. Margaret, I can see your hand up.
Thank you. Meg mentioned that most clinicians today are well educated, and I think that that's a very true point, and they should trust their gut instinct when they're looking at their patients and thinking, right, this is how I care for you in hospital, this is how I look after you and make sure you don't fall. But I think that they need to think also, as has just been stated, about what happens when that person goes home. We don't want a further fall, which means a readmission and further costs to the whole system. And I think it's looking at what can be done to prevent that recurrent fall, and look at, you know, sort of once people leave hospital, how many of those falls do occur?
Thanks, Margaret. I think really, really good points. Now, I can see that my chat is going nuts and lots of people are throwing in questions, but I have to say I have had absolutely no capacity to monitor it. So I'm just going to throw this open to people on the panel. This is your last chance to say anything that you think needs to be said or touched on. So I might just, I'm going to go around in Brady Bunch order. Keith, have you got any last words of wisdom for us?
Probably as a way going forwards, I think all of the panel would be very happy to have further dialogue with any of you. And so feel free to flick us emails, anything that you agree or disagree, or you would like to have discussions about what could be done going forwards. Communicate with the various people on the panel. We'd be happy to participate in that.
Thanks, Keith. Alison?
Yes, nothing further to add. I think I agree with Keith.
Great, thanks. Francis, any last words?
I think everyone said it all. We need more research and more collaborations between policymakers, clinicians and researchers.
Great. Terry, last words for us?
I think one of the things for everyone on the panel today, I mean, the panel, everyone in the webinar, that you've got a lot of people here extremely experienced on the panel, but just remember that we all started somewhere. For me, I was a clinician. I was frustrated about how my hospital went trying to prevent falls, and I was sick and tired of my patients falling over, and I wanted to do something about it. And, you know, I'm now 21 years down from that point. And a bunch of people on this panel today have helped me and been my partners along the way in that sort of thing. So I'd encourage anyone on the panel today, if you are wanting to do more to prevent falls, and just know that there is a supportive community in this space, and that don't be afraid to speak up, and that we can be here to support you.
Thanks, Terry. We're all very nice people on the panel. Meg, I'll throw to you for a last word.
I think let's get organised. You know, let's not be random anymore. Let's get organised. Let's work together, and really, really importantly, let's co-partner or co-produce whatever we do with patients themselves and other consumers.
Thanks, Meg. Ronald, last word.
I agree with everything that's been said so far. So I think that's been great to have this discussion. I suppose the only thing I will perhaps put out there is we might need to look further upstream. We need to prevent people getting to the point where they are at risk of falls. So I think keeping them out of hospitals through whatever means we can to keep them healthy, I suppose is the way I would probably look at this a little bit.
Yep, Ronald. I think that's a really good point. I mean, that, you know, I suppose the focus of this session has really been on preventing falls while people are in hospital, but obviously that is only a very, very small part of the picture, and we need to also think about that broader view of things. Jackie, any last words from you?
No, just to everyone said it, I think, but just to encourage everyone that's watching today to get involved. If you're passionate enough to be watching this, and as Terry said, like if it annoys you, if things are annoying you, then get involved and work towards being the greater change for your organisation and your patients.
Thanks, Jackie. And I think to wrap up the panel discussion, I'm going to throw back to Margaret to give us the final thoughts from her consumer perspective.
I think from the consumers, I think we would like to sort of say thank you to everybody who works in the hospital setting for the care and concern that they show to all of us as patients. And to the researchers, thank you for putting a lot of work into trying to make things better for everyone that has to walk through the hospital doors. But thanks again, Kathy, for the opportunity.
Oh, thanks, Margaret. I think it's been, absolutely fantastic to hear your thoughts and get your views on things. So that wraps up the panel discussion. I'm 1 minute over, so I actually think that's actually a pretty good outcome in the whole scheme of things. And I am going to throw back to Terry, who is going to wrap this session up. So thanks, everyone.
Thank you very much, Kathy, and you've done a sensational job emceeing today's workshop. Eddie Maguire and Glenn Rich should look out. You've got a future in this space, I'm sure. Now, Kathy Pickett, if you wanted to put the links to the slides that we're finishing on, we would like to invite everyone to participate in a post-workshop survey. It's a very brief survey. It's similar to the one we sent out beforehand. But again, it very much as a theme for what we've been discussing today, we are interested in what you want to do. As a team of people who've been working in this field for a long time, we want to try and be of service to you, and this sort of information helps to tell us how our efforts might best be spent. I think that while you're doing that, so if you can click onto that now and please complete that survey, I'll keep summarising, I guess, some of the main points that I saw from today in the background. First of all, we started off very much hearing the consumer perspective from Margaret, and really hearing about the importance of caring for the patients, but I guess to respect the liberties, to respect their capabilities, not to patronise, and to really understand and deliver our care from the patient's perspective. We then heard from Meg, who provided us with some updates onto the evidence that exists and provided some great links to different sources such as the NICE guidelines and the Cochrane review, and really encouraged us to look at educating our patients and our staff, and to really engage with leadership as a way to move forward with falls prevention in our hospital settings. We looked at then the work that Allison presented, and really came to appreciate the magnitude of the cost of the resources that we are putting to falls prevention. And I think by combining Allison and Meg's presentation detail, we get an appreciation of how much effort is already going into falls prevention in the hospital settings and the context that we are currently operating from for our practice and for our research. You've heard from me and about the different ways that we can do research and try and answer questions using some non-traditional research techniques suited to our particular context of falls prevention. Then we heard from Francis, who really gave us a message of tailoring our approaches to the individual context and using co-production as a means to really work in partnership with our clinical providers and researchers, that they can work together to try and address the localised needs of health services. Then Keith shared with us some of his insights and really gave us a message that I think oils ain't oils necessarily, and that there's need to appreciate that, simply lumping all intervention approaches that carry a similar name in together may not necessarily represent the nuance that could be there, and different ways of doing things that might improve how certain interventions look in the research literature compared to various studies that are done with different approaches. And certainly I think we've had discussions in this panel which have been great in terms of highlighting the need for falls responsibility to be shared, that we do need to respect a range of realities in terms of the patient's rights, in terms of our resource limitations and our rehabilitation goals when we think about where we set our goals for falls prevention as a hospital, looking at how we use our data and how we document our data and the things that impact on that, the need to have basic strategies for all, the controversies over which falls prevention interventions we could potentially let go of and which ones we need to maintain, and also really the potential opportunities that we have in front of us in the weeks and months and years to come, and whether we as a group, as a network, and our broader family of clinicians and researchers across the country, whether we can potentially do something together and structure up and have a clear strategy for trying not only to help create research evidence, but translate research evidence into practice across the board and really enable the capacity of clinicians to really grow in the falls prevention space. So I think that's a fair summary, and I think it's time also to thank a number of people who've been instrumental in getting our workshop together today. Kathy Piggott and Angela Jones have been wonderful in terms of being able to draw us together. We've had a number of Zoom meetings in lead up to this. A number of the panel members have been contributing to this. We've got a number of thank yous to Margaret Thomas for joining in and sharing her consumer views, to all of our panel members who have given up their time to join us today, and also thank you very much to the participants for joining with us today. It's been fabulous to have your input and to see where your thoughts are that can help guide us as a group moving forwards. Kathy, I don't know if there's much else left to be said. I think we'll send out some email correspondence to everyone online today, or everyone who registered. So I saw some links for various studies. I think if we send out a list of all the references and some links and which studies they relate to or what they might say, that might be good. Also other resources. There's been a number of requests for resources online in the chat today as well. I think that'd be a very good thing for us to do in the next few days. Kathy, anything else that I've missed?
I don't think so. I think there's also been a number of requests for whether there'll be copies of the presentations. And again, I think the webinar has been recorded, so people will be able to see that. And I'm sure we probably just need to touch base with all of the presenters about whether they're also happy to share copies of their presentation or not. So again, we'll just, we will update you all on that.
And the survey will be sent out once we finish this webinar too. So it comes when we complete it.
Okay, fabulous. Thank you very much, Kathy. All right, well, thank you everyone for being on board today. On behalf of the group, it's been fabulous to have you. I've enjoyed myself. I always enjoy listening to all these different perspectives, and we hope to have further contact with you, the nature of which will be revealed next time.
See you later, everyone.
Bye.